All right, we'll go ahead and start on time. Good afternoon, everyone, and welcome to today's ACCP Transplant PRN webinar. My name is Angela Logan. I am a transplant pharmacist at Tampa General Hospital, and it is my pleasure to moderate today. Today's webinar will be on how various transplant pharmacists are utilizing Epic to optimize their clinical practice in the ambulatory clinic setting. We are honored to have 3 different speakers to present for us today. In a moment, I will be turning the slides and speaker over to our first presentation, but there are a few quick notes I do want to go over. For our audience members, please ensure that your microphones remain muted for the duration of today's presentation. The mute button is located in the lower left-hand corner. At any point during the presentation, if you have questions for our speaker, please make sure to submit your question by using the chat functionality at the bottom of your screen. And please send your questions directly to myself, the moderator for today's webinar, to minimize any possible interruptions to our speakers. We will take questions at the completion and end of all the presentations. There will be no CE offered for today's webinar, and today's webinar will also be posted on the ACCP Transplant YouTube channel. If you experience any technical difficulties during this webinar that are not fixed by logging out, please try refreshing your internet connection and also make us aware through the chat functionality. It is my pleasure to introduce our first speaker, Dr. Jillian Descourouez Fose. Dr. Fose is an abdominal clinical pharmacist at the University of Wisconsin, and she has over 15 years of experience. Her primary role is to provide care to abdominal transplant patients in both the inpatient as well as the outpatient clinic arena. She's a collaborator in the founding and ongoing management of the CMV Stewardship Initiative. Additionally, she has implemented and continues to help maintain the abdominal transplant anemia clinic. Both clinics have depended on innovative uses of Epic for the development and ongoing daily operations. It is my pleasure to turn over our first speaker to Dr. Fose.
Thank you, Angela. So thank you to ACCP for inviting me to do this. Hopefully the slide changes here. There we go. So I'm going to be talking about episodes of care. I wanted to give a little bit of background of how we got to the point of using these episodes of care. So as Angela mentioned, I was involved in developing both the antiviral stewardship clinic and the anemia clinic. And when we created these, they're both primarily ambulatory clinics. We need ways to track our patients. And they also needed to be able to do a number of things. So we needed to be able to schedule follow-up dates because these are going to be ongoing tasks that needed to be completed. So we need a way to, first of all, gather the patients, get them on some sort of tracking device, schedule follow-up dates or times we need to look at patients, indicate, why patients, whoops, it went forward, but that's okay, indicate why patients are being enrolled in the clinic. And then also have some sort of format where we can share out the information with other providers or other practitioners who are caring for the patients. And so before I start, again, getting to using the episodes of care, kind of how our clinic works is, we have all these different providers being involved in the care of the patient. So we have physicians who might refer a patient at a time of a diagnosis. So either diagnosis of anemia of CKD or diagnosis of CMV or something like that. So they need to be able to get in touch with us, let us know they identified a patient that we can then take over and manage. We have the pharmacists that work on the inpatient setting that are actively looking for patients who would meet the criteria and sending them to us. So these would be like the patients that we're going to monitor for CMV high risk or those patients on letermovir. So we need them to be able to have a way to identify patients and get them to us. And then transplant coordinators. So obviously they're the ones providing long-term care. They would need to be able to refer patients for intervention, but then also follow along and see what's happening with the patient's care. And so we tried a number of different things over the years, particularly with anemia clinic, and through trial and error, we eventually landed on using episodes of care. Sorry, there's a bit of a delay, but episodes of care are nice because you can group patients. There we go. So they can be utilized to link multiple encounters that a patient shares based on a condition or treatment. So for example, we can have one report that lists everybody who has an episode of care for CMV management. So that means whoever's functioning in that clinic can run the list and see all the patients who've been referred. The providers can also see patients who have a CMV episode of care. So if they're wondering what's happening with the CMV clinic, they can go to that episode of care, see the notes, see what's been going on with the patient. The coordinators can see it. The inpatient pharmacist can see it. So that's what's nice about episode of care. It also allows for focused care because you're, again, grouping patients with a clinically like population of patients. So we have one report specific for anemia patients. We have one report specific for CMV patients. Our warfarin clinic, which I don't function in, they have their own report. So the person who is going to be following the patients doesn't have to wade through one list that's got all these patients combined. They can just log in and they'll have a list of patients that they're focused on clinically for that day. So most of this talk, since we're talking about how to use Epic, is going to be how to actually do this, because I thought it would be helpful to show people. You may not have this functionality without you reaching out to your IT team. So may or may not be familiar to you, but I just wanted to give some screenshots of like, how is this actually done? So if we have a patient that we identify would fit within one of our clinics, we have to first create an episode of care. So we have these RPH tool buttons within our ambulatory encounters, and they allow us to do a variety of different things like make medication charts. They're very pharmacist tool specific. And one of the options we have that within that is to create an episode of care. So it's pretty easy. You can see on there, you can click this episode. If a patient has other episodes, it would show up there. So all of our patients at UW have a transplant episode. They may have like a specialty, the UW mail order specialty transplant episode. And, that is used by the mail order pharmacy. They can have a variety of different episodes. So pharmacists are not the only people who use these, which is another reason that we thought it would be nice because in general, the transplant department is used to using them. So you click on episodes and then you can create a new episode. And when you create the episode, this is where you can kind of indicate why you're enrolling the patient. So for this example, I did anemia. So usually for the name, we'll put something like transplant anemia clinic. The name doesn't specifically matter because that's not how you're going to tie the patients together. It just indicates what the enrollment is for people who are looking. And then you can put in a type, and within that type on the next slide, I'll show you, you can indicate why the patient is being enrolled, which is then helpful for the reporting that you're able to run. So we use this UWRX medication management program. And again, this is like an umbrella for all of the pharmacy departments. So people that are doing warfarin management, the lung transplant people who are followed by those pharmacists, our CMV, you can indicate then all that within the episode of care, but creating the episode is the same across the board. So then once you create the episode, I was saying you can then go into this smart form and designate program specific details about why the patient is enrolled. So these are all of our pharmacy episodes of care that exist within Epic for us. So again, you can see there's a lot of pharmacy ones. I mean, transplant's not the only one who does this. So we all use this same form, but then we go in and fill it out. And so when you're clicking these buttons on the smart form, that's what then is going to put the patient on your report. So you have to be accurate when you're doing it. But we would pick transplant. I think I have some screenshots that go through, and then that opens up another slew of buttons, which you can then indicate why they're enrolled. So we have a lot for CMV because we like to identify specifically why we're following them. So you can see on there, we follow people for treatment. The in-process one, that's usually the indication for the resident, the ones that the resident's following. We have GAN-resistant CMV. You can indicate if they were enrolled because their creatinine clearance is less than 60 and you're wanting to keep an eye on their valganciclovir. We use CMV priority 2 for people on letermovir. So you can see there's all sorts of them. So you can get as many buttons as you would like. Or on the flip side, our anemia clinic, that's also shown here, we just have 3. We have people that we follow remotely because our anemia management protocol includes people that can't come to clinic. We have people that we physically see in clinic, so we have a clinic button. And then we also have people we're following just for iron deficiency that we're not yet administering ESAs to, so we have a button for that. And then there's a couple other buttons that you just fill out, like who referred them. So usually it's the provider. You could indicate like the coordinator or someone else. And then is this care being done under a protocol? For us, it is. We have a CMV protocol as well as anemia protocol. And then it asks you when you hit yes, like which protocol. So all of this gets tied into the episode and is a reportable data that you can then pull out. So that's sort of how you create the episode. Just for some background, because I thought maybe people who don't use these would like to just see how that physically or how that works. And then I wanted to talk through how we use it on a day-to-day basis. Like, how is this report helpful? So if we go back to kind of what our goals were, we needed something that we could schedule follow-up dates. We needed to indicate why they were enrolled. It needed to be accessed by multiple users and seen by all providers. So if you're coming in to work one of our clinics, you can run a report based off the episodes of care. So within our toolbar, we have an analytics catalog. And when you open up the analytics catalog, you can find all sorts of reports, but we have our 2 specific reports built based on our episodes of care. So we have the anemia one, and then we have our CMV one. So depending on where you're working, you would click the button and then it runs the report. So our CMV report typically has like 250 patients. It can take a few minutes to run, but the anemia one's usually about 50. So that one runs a little bit faster. But what the report looks like then is this. So this is just a screenshot of our CMV one. It has a little bit more data than our anemia one, but based on the buttons that we clicked, as well as additional data we had built into the report, you can use that to kind of distinguish who you need to follow up first. So we had them add in for this report the most recent creatinine, because we were thinking like, what if there's a big change and we want to see somebody who we might need to adjust their val site. We don't really use that as much because now we're more of a letermovir program. We wanted to be able to pull when their last CMV PCR was. This didn't prove as helpful for us because we get a lot of outside PCRs and it doesn't necessarily pull that in, but occasionally it's helpful because if they got one at UW, it will show that it was drawn recently. It'll pull their white count and their TACRO, because those are all things that we evaluate in the clinic. So if you were going to create a report for yourself, you could work with your IT team, and they are able to add these different columns in based on what you thought was going to be helpful just when you're kind of sorting through people. So the way that we function in the clinic is we have the next outreach. And so that was tied to the buttons that we filled out earlier. And we would click that and then we run, go through all the patients that are due for that day. So what that means, I didn't take screenshots because I think most of you know how to do a telephone encounter. So basically we open up the patient's chart, we create a telephone encounter, we would document whatever it is that we're documenting, either for their anemia care or for their CMV care. And then there's a button that you can link to the episode of care encounter and set your follow-up. So within the RPH tools, again, that we have in the ambulatory setting, that's how we link our document to our encounter to the episode that we want to link it to. So like I said, you can see like specialty pharmacy has a lot of episodes of care for our transplant patients as well, but I would just click the episode of care that I'm working under that day. So in this example, it was CMV stewardship. Then it lets you track your patient outreach. So this is what's going to set your follow-up date on your report. So we always say it's a telephone call, just that's the way the report's set up. And then you can indicate what they're contacted about. So we have 2, again, we have those anemia ones or the CMV one. So for this one, I picked CMV, and then you can put your next contact date. It's kind of handy because it'll give you some, you just want to follow them in 4 weeks, like for anemia patients that are doing every 4, it gives you the date, but you can also change it. And so then when you do that, it will kind of rejuggle the list and move that person on your episode of care report down to that date. So then it kind of bumps them down. You completed them, moves them down. And the nice thing is it's real time. It doesn't always refresh when you're right on it, but if someone else ran the report while I'm doing the report, they would see I just done that person and that it moved down to the next follow-up date. So we wouldn't be duplicating our work with each other. So that's in a nutshell, episodes of care. I'm sure you might have a lot of questions, which you can ask at the end, or feel free to email me. I have my email coming up. But I just wanted to touch on briefly, like what I think are the pros of episodes of care and what I think are the cons. So I do think they're multi-user friendly. Since this was kind of abbreviated, I didn't really give a lot of screenshots of how other providers would locate them, but they're just one of the tabs in the chart. There's a tab that says episodes, and then it shows your episode. You can open it up and it has all of your linked episodes or notes that were linked to that episode of care for easy access. And again, it's not only is it multi-user as far as other providers can see it, but it's multi-user friendly. If multiple pharmacists are going to be working on the same report, they can both access it at the same time. It allows for the running of reports. So not only can we run the reports that we run on the day-to-day basis, but we've been able to work with IT to run reports later. Like if we wanted to see year to date, how many patients have we followed for a particular reason, they're able to help us get that information because all of the enrollment buttons are smart buttons. They can pull that on the background and give us that data. So that's helpful, like when you're trying to justify the growth of your clinic, like you want to say, we went from an average daily follow-up of this to this, or like we primarily followed these kind of people. You can pull that from these reports. And again, it's one report for tracking similar patients. So if you're CMV or anemia, you just log in, run your report, and it's all your patients for the day. And then it groups all the notes within one episode. So again, you can pull up the episode. All the notes that were tied to that will show up. Some of the cons are it needs to be built by someone from IT. At least in our experience, we have a IT point person who helps us create the episodes of care as well as modify them if we ever need to add new buttons about why we're enrolling them or things like that. And it requires a lot of decision trees. So you saw, like you click one button, it opens up more decision tree. You click another, opens up more. So again, it's kind of IT heavy. And then other providers need to know where to locate the episode of care. Again, we have transplant episodes of care. So I think the providers are familiar with going to the transplant episode of care, and it's similar to that. But if you were at an institution who doesn't use episodes of care, that would be something you'd have to educate your providers on how to find this information. And so that's all I had. Again, we're going to save questions for the end, but hopefully it just gave you some food for thought. The people that I've talked to that use Epic, I haven't found a lot that use episodes of care, but we found it to be super helpful. So hopefully it gave you some ideas of how you can manage your clinic moving forward. And so I will hand it back over to Angela.
Thank you so much, Jillian. It's my pleasure to introduce our next speaker, Dr. Mary Leick. Mary is the solid organ transplant pharmacist coordinator at Nebraska Medicine, and she's also the clinical assistant professor at the University of Nebraska Medical College of Pharmacy. She's board certified in both pharmacotherapy as well as solid organ transplant, and she serves as the chair of the BCTXP Specialty Council. While her primary practice is an inpatient adult liver and intestinal transplant, under her leadership, the abdominal transplant program at Nebraska Medicine has added 4 new pharmacist resources in the last 7 years, and this includes 3 ambulatory transplant pharmacists. She has been instrumental in empowering her fellow colleagues to leverage the resources within Epic to help streamline and justify these new positions. The growth of transplant pharmacy in the ambulatory space through CPA expansion and clinic presence has been an exciting part of her tenure in Nebraska Medicine, and she looks forward to continuing to see how the practice advances in the future. So I'll hand it over to Mary.
Thanks, Angela. So to start, I'm going to take us back in time a little bit. So I started at Nebraska Medicine 10 years ago, and we'll see if these slides move forward. All right, so this was in 2015 when I started at Nebraska Medicine. We had 1 transplant pharmacist for each organ group and a pediatric transplant pharmacist. And at that time, those of us who were practicing primarily on the acute care or inpatient side would provide clinic support ad hoc. Our pediatric pharmacist was doing a little bit more in-clinic work and utilizing the resident in that capacity. But as we started to provide those services, we didn't have capacity to continue that. And so I worked alongside one of our managers to start advocating for positions. And this is our current Nebraska Medicine Transplant Pharmacy, and we'll continue to expand next year with an addition of another inpatient outpatient resource for the liver group. But as you can see, there are now 4 ambulatory positions across the organ groups. We've also added an adjunct transplant pharmacist that provides a lot of cross coverage and a transplant pharmacy technician. But what we've identified is as our ambulatory services have grown, we really have specific needs that need to be addressed. One, we have to have increased communication. Our service is much bigger. The comprehensiveness of our services have changed. We have collaborative practice agreements across organ groups and have a lot of our members of the pharmacist team on those groups. And so we want to make sure that we're providing communication, not just among the pharmacy group, but also with our providers and our transplant coordinators. Again, we want consistent documentation, and that is key, especially as we have this larger group of pharmacists that practice in each area. And while we each have homes, I may cross cover into the ambulatory space one of every 8 weeks. And so if I'm not doing that consistently, making sure that we find ways to ensure that what I'm providing is the same as what my ambulatory pharmacist colleagues are providing. And lastly, as many of you know, when you add 4 plus resources to the service, at some point the C-suite might be calling and asking, what are we doing with these resources? And so finding ways for workload justification and data capture are really key. And so what we've really done is utilized Epic optimization to try to address each one of these needs. So I liken this to a toolbox. So these are just all tools within Epic rather than just one size fits all. Each of our organ groups operate separately. So our kidney team have different kidney providers, our liver team has different liver providers. And so each organ group has really identified which tools work for their team. And I'll kind of walk through each one of the ones that we use and ultimately give you some insight into how we're using it here at Nebraska Medicine. So I'm sure many of you are familiar with SMART phrases, but these are just standardized phrasing that can be shared among transplant pharmacists. And what I have found with these SMART phrases that I think are really key is that it provides consistency and documentation across care providers. It ensures that there's clarity of therapy plans. So, if I'm covering just for a day, I'm able to quickly dot phrase something or SMART phrase something so that I ensure I touch all the pieces that my other providers would touch, and then it enhances our efficiencies. Each of our organ groups have multiple collaborative practice agreements, and so not spending time making sure that we're typing it out exactly the same way. We can just dot phrase it and it can be moved forward quickly. So for our collaborative practice agreements, here's one just example of what we do for our prednisone tapers and make sure that we're addressing what their current dose is, the labs that we want to be assessed for every patient, as well as what the changes will be. And then there's a nice little reminder of our practice strategy, which is, sending the new prescription. Another place that we play a large role is in transitions of care planning, and any patient that's discharged to an acute rehab facility will ultimately have a clinic appointment with a transplant pharmacist when they leave that rehab facility. And we play a large role in sending those prescriptions to our pharmacy and ensuring that we have those ready for them when they come from the rehab facility. And we utilize our pharmacist technician to help deliver those medications to the clinic space so that we have everything we need when we meet with that patient. And this dot phrase or SMART phrase can be really effective at making sure there's a communication of that plan. And then I'm sure all of you guys have these for your transplant evaluations and clinic visits, but these SMART phrases I think are really key as you grow in your number of pharmacists that are caring for these patients, as this just ensures that we have a nice stepwise approach of the tasks that I need to complete as I'm doing an evaluation. Like I said, when I'm covering ambulatory clinic every 8 weeks, it's nice to know that I can come in, use the dot phrase, and I can make sure that I'm providing the same level of care that my ambulatory transplant pharmacist is providing, and it's very consistent, and that providers can know that what they're getting is going to be the same regardless of who's present in the clinic at that day. And again, these nicely pull in some of the data that we want to be captured, so I'm not having to look up their CMV, serology, it just pulls it in automatically. But what's really key that we've started utilizing at Nebraska Medicine is our SMART forms. And these forms are able to discreetly capture data for our ambulatory clinic activities. It's very standardized. There's less free text, but it allows us to track patient outcomes and the activities that we're pulling and doing, so that way we can identify patients that may need follow-up as well as show all the work that we're doing. So here's an example of our transplant pharmacist assessment. So we'll be identifying whether the patient is in their initial assessment, a follow-up, or just a chart review from our prospective monitoring. How we engaged with the patient, whether this was just for documentation purposes, or if we actually spoke with them on the phone or had a telehealth visit. What organ was the patient had transplanted, and then whether this was pre or post-transplant. The recommendation that was made is quickly checked, and then any CPA that you utilize can be captured here. There is space for comments of what actually was done if more explicit information is needed, as well as the time spent and whether education was provided. All of this can then be captured into a note. And so here's an example of one of those SMART forms. So it pulls in all of those discrete data, and then the pharmacist can leave more specific recommendations for what they did and what kind of care they provided for that patient, and it nicely captures that time spent. And then ultimately, when we pull that data from behind, we can say how many minutes of time transplant pharmacists were answering or doing ambulatory care related activities. One of my favorite ways that we take care of patients within the liver transplant group is the use of clinical reviews or TAS. And this is a little bit more specific for that organ group, as the kidney transplant team here doesn't use this quite as much. But what a clinical review is just a task that's assigned to either a specific user or a specific pool. And for us, we have a transplant liver pharmacist pool where multiple pharmacists are assigned to that. And this can also be included for MDs or transplant coordinators, and we have pools for each of those groups as well. And then these clinical reviews can be sent back and forth, and a list of those clinical reviews can be pulled by each of those responsible providers. Examples of ways that we use this is that when I discharge a patient from the inpatient space to the outpatient space on the day of discharge, I will send a care plan follow-up to the clinical review so that my ambulatory colleague can know that patient was discharged and have insights on the specific activities that I think that need to be addressed moving forward. This has really enhanced our transitions of care and really ensures that we have a nice streamlined process as they are moved to be seen in clinic. Our transplant coordinators and MDs will utilize this as well, and this can be addressed as patient-specific questions about immunosuppression, other medications, other CPAs that we may be utilizing, including our prednisone tapers, as well as vitamin D or osteoporosis management. But then what does this look like? Well, this is my screen of where I can run this report. So I'll click and run the report, and then ultimately this report will generate, and there's usually upwards of 50 or 60 clinical tasks, and that can sometimes feel overwhelming, but in reality, the due date does differ. So you can sort this by the due date, and oftentimes I will filter this list when I'm covering ambulatory by the due date itself and look at the things that need to be addressed. As you can see, there's a variety of things like prednisone tapers, immunosuppression management, a new transplant discharge, as well as cytomegalovirus monitoring that we're doing in these tasks. When new tasks are sent on the day of, we do have some priority that can be identified, and this is a way that when transplant coordinators or MDs send us something new on those days, we'll be able to catch those sooner and know that they need to be addressed on the same day. We also sometimes will have to rerun that report as it does refresh actively as clinical reviews can be sent throughout the day. And lastly, we do a lot of prospective monitoring for our patients, and this is monitoring things like renal functions, changes in lab values, follow-up on vitamin studies that we're doing. This reminder list can allow for more targeted follow-up for whether it's all patients or just high-risk identified patients, and give some specificity to the dates and lab frequency, as well as new results that may need to be addressed, giving some insights and some clicking into the sticky notes, and then potentially where that patient may need their medication sent to. So a reminder list is just going to come from a shared list on your My List part of Epic. And then ultimately can be set up with reminders for when those patients need to be seen. So, these things are a little bit old, so don't think I haven't looked at patients since May, but you can see that this screenshot, you can see that labs were from May 6th, and there's on Mondays and Thursdays. And if you scroll over to the new result section, you can see that there'd be a new result that needs to be reviewed. What's nice about this is that if you're working on a daily basis, if you've time marked that you've reviewed all those labs, this result flag will go away. And so as the ambulatory provider or the pharmacist is looking at her list, she will know that there's either nothing to look at or there's something new to look at, and can really try to increase efficiency so you're not spending time going in and out of charts when you don't need to. But obviously, Epic has a ton of tools, and so other tools in our toolbox that we see are the patient advice request. And so this is a screenshot of some of the advice requests that are out there for our kidney transplant group, and these can be taken by anybody associated with that pool, and we utilize pools just to share the responsibility. And for those of us who may take PTO or take time off, by having a pool, we're not requiring them to send the their inbox to somebody new when they're off. It just always goes to a pool, and then you just can done those independent once those are completed. And staff messages, again, are another way that are not within the Phoenix platform of Epic, but rather just a more general platform. And this allows for, again, providers or nurse coordinators to send messages regarding patient care, giving more specifics about things that need to be addressed. And obviously, as many of you know, there are a variety of Epic tools that can be helpful in streamlining your practice. We utilize them both in clinic and outside of clinic to both capture our data as well as provide consistent documentation. But really what we have identified is that really engaging our other transplant providers and creating a program that works best for the physicians, the nurse coordinators, the pharmacists, and making sure that everyone's on the same page can be really helpful for optimizing the use of those desired tools. There's not a one size fits all because we all have different numbers of patients, different ways of follow-up, and so ensuring that we're working together is really key. But I'm happy to discuss more or answer questions about how we're utilizing those things moving forward, and I appreciate the opportunity to share some of the insights that we've had.
Perfect. Thank you so much, Mary. I do have some questions myself at the end. But I'm going to move forward, and I'm happy to introduce our very last speaker, Dr. Evan Clemens, and he will be discussing leveraging Epic for a new pharmacist-managed immunosuppression monitoring service. Dr. Clemens is a transplant clinical pharmacist at the University of Washington Medical Center, where he cares for abdominal transplant recipients. He splits his time between inpatient kidney transplant as well as liver transplant rounding teams in the ambulatory care services. In the ambulatory care setting, he works in a unique pharmacist-managed long-term tacrolimus monitoring clinic, providing telehealth therapeutic drug monitoring service for the kidney transplant patients. Without further ado, I will hand over the slides and speakers to Dr. Clemens.
Thanks, Angela, for that introduction. So let's see here. Yeah, got the slide control. So as background, we had our kidney transplant pharmacists involved in the clinic since I started in 2011 and for a long time before that. And our kidney transplant pharmacists in that role provided some pre-transplant education. We did inpatient rounding and discharge teaching, and then we did 2 routine visits in the ambulatory clinic. The first one at their first transition post-op visit, and another a couple months later to assist with prescription transitions. But immunosuppression was managed by the transplant nephrologist until they checked out back to their referring nephrologist, usually around 3 months post-transplant. And the unmet need that we saw in our patient population is that there was some variability in the quality of that immunosuppression management after it was checked back out to the referring nephrologist. And so we had requests from our transplant nephrology leadership to add a pharmacist position to assist with this in terms of managing their immunosuppression in this 3-month to 3-year timeframe where our program is still responsible for post-transplant outcomes, but we were not directly managing the immunosuppression. So we started off by implementing a collaborative practice agreement where we actually already had one established for our regular transition to care clinic, and we just broadened that to include that the transplant pharmacist would manage immunosuppression, and we set some expectations up with the transplant nephrologist, where the transplant nephrologist would still establish the target goals for the CNI levels, and then also an understanding about co-management, where we were responsible for immunosuppression, but other lab results would still be done by the local nephrologist. And then when they came physically back to clinic, as they would for longer term follow-up with our transplant nephrologist, the transplant nephrologist would still be responsible for results on the day that they physically saw them. So we were notified about these patients through a referral to pharmacy process and that we set up. And so usually this happened around that checkout time when people were transitioning back to their referring nephrologist around 3 months post-transplant. And then after 3 years, then the referral would expire and we'd release control back to the local nephrologist. We actually have implemented a process too to have these referrals redone annually. So we keep track of the original referral date and then when the renewal of the referral needs to happen. And then we have visits with the this immunosuppression management pharmacist at their initial referral, and then coinciding with any further long-term follow-up visits. So if they're coming back to see the transplant nephrologist at 6 months or 1 year, we would tag on to that visit and see them as well. And then in between those in-person visits that we're still having with the patients, we would do telehealth adjustment of the immunosuppression doses based off of their lab results. So this is a slide showing the referral, and I'm sure many people have seen Epic referrals before, but this just shows how we set this up, this referral to pharmacy that had the associated diagnosis, the department of the post-kidney transplant department, and then the comments that describe what the collaborative practice agreement entailed and what things we could order, basically. So then once we get notified about these referrals, usually in person by the transplant nephrologist, and we kind of have a sense of on our list who's been transplanted recently, just through a simple report that says, oh, who's the recent transplant patients, and then on our clinic schedule, we can see we can organize people by transplant date and see who's coming up on this 3-month time frame. So we sort of have a little bit of anticipation of like, is this person close to checkout? Could they be referred to us? And then once the transplant nephrologist says, oh, okay, yeah, it's so-and-so's checkout visit today, I'm sending them back to Dr. So-and-so, and I'd like you to start following them. Once we hear that, we go into the transplant tab, and we had a few things built for us by our Epic IT team to allow us to track these patients. One, we had a protocol made, and in Phoenix module with transplant, you have this transplant tab, and one thing you can do is add a protocol, and that protocol can then fire off a variety of other rules and reports and things. And so we put a protocol that says primary immunosuppression management is by the transplant pharmacist. We also add ourselves to the care team, and there's actually a role set up on the care team of transplant pharmacists. So we add ourselves as the designated transplant pharmacist. And then we also put in, of course, the calcineurin inhibitor threshold. Additional place we wanted this to be because the transplant coordinators were using this episode note as a way to quickly identify patients and kind of where they were in their follow-up. And we decided, well, we'll put a little blurb in there as well. This is a smart text enabled field, so we could put a blurb in there that says the UW transplant pharmacist is managing immunosuppression until 3 years, and then we put the date. And you'll see Alyssa Boyle's name on here. That's one of my colleagues. She's actually primarily responsible for this clinic, and really a lot of the credit goes to her of setting this up. And she does this 75% of her time, and I do it the remaining quarter of the time on a rotating basis. So essentially every 4 months I come in and relieve Alyssa and then she gets to do something else for a period of time. So then also on the transplant tab under the forms section, we had another custom section built just to be able to type a free text field of notes and then have reports run off of that. So we put this transplant pharmacist info free text field where we were able to establish a due date for labs that only we control because the rest of our team uses checklists, and I'll show a slide about checklist tasks, but we wanted a different place for us to have full control that nobody else really would access and use. So we would ultimately be responsible for that lab due date. And then we put comments in there about how often we're doing labs, where we can expect to find them, and then what the referral date was. So then on the checklist, we still do use the checklist tasks, and this was mimicking the existing workflow. So in the existing workflow for patients that were in the first 3 months managed by their transplant nephrologist, we would have this lab tracking task for our students. And we actually have like undergraduate students that come and work for us and for the department, for the Transplant Institute, and they will probe for results. They'll actually ask the outside lab, hey, do you have results on this patient? They'll call them, or they'll monitor the fax machine, and then when those results get sent to us from outside labs, they actually enter them into our Epic instance, and then the nurses also have their own separate checklist tasks to double check and ensure these labs get reviewed, and that they follow up on patients that are past due. So we were overlaying our care on an existing system where the students and the nurses were doing this for the nephrologists. And then after they were checked out, the lab tracking was for review by our transplant nephrologist, but as a duplicate, and we wouldn't always get those labs because it was primarily the local nephrologist responsible for those. And then we would just be copied as kind of an FYI for our transplant nephrologists. And so here's the Epic in-basket. And, again, this was an existing workflow, and we figured out, well, how are we going to overlay our work onto what's done here in discussion with our transplant nephrologist, just to make sure labs didn't get missed or unreviewed. We still had the person ordering the labs, the name on the lab order was the transplant nephrologist. And so the transplant nephrologist still comes up as authorizing provider, even though under the CDK, hypothetically, it could be us. But these labs are usually ordered as a panel with a bunch of other things, and we weren't managing like their other conditions. We were only managing their immunosuppression. So, we weren't looking at the urine results or the potassium or other things, or deciding, if the patient needs a biopsy or a different follow-up or something like that. So the transplant nephrologist still wanted to see these results, knowing that they didn't have to take action most of the time, because often it was just us for the immunosuppression, adjusting the doses of their tacrolimus. And so in this screenshot, you can see we use a pool, the post-kidney results pool, which pulls together all the results under the names for our transplant nephrologist coming to our department. And then I'm able to then filter using either sorting by columns or specific filters to filter on the role of the transplant pharmacist. So if they have a role of the transplant pharmacist on the care team, I can sort them by that. I can sort by whether they've got a tacrolimus result, whether it's new, whether the collection date. So you can see it's pretty hard to see because it's small, but I have this sorted, in my view, under transplant pharmacists primarily, and then second on the collection date, and then third on whether the result is critical or not. And when you set the threshold ranges on the transplant tab, tacrolimus values that are out of that range show up as critical results. And so you can see here the one that's highlighted, the tacrolimus level was 9.9. It was a critical result, meaning it was outside that threshold range. The other thing that's helpful about the protocols that we set up is that the first view that is defaulted when you click on one of these results is this KP review screen, this report that's down at the bottom. And you can see we created a best practice alert, this banner, this big banner, because one of the concerns was the transplant nephrologists are not going to know, which of these results they need to review and which ones are the pharmacists. So the ways that we address that are we tried to put it everywhere so that it was very clear. So if they happen to see that column that says the transplant PharmD is kind of signed in as a care provider, then hypothetically they want to touch that tacrolimus level, or if they see this best practice alert, or if they look at the protocol section and see that the transplant pharmacist is monitoring. But even with all these checks, sometimes occasionally the transplant nephrologist will speedily get to the result before we get to it. But usually we're pretty prompt at reviewing the results, and it only comes up very rarely that they review it before us. So here's an example of the filters, the different filters that we have set up on the in-basket. And for example, you can set up a filter that says, oh, I want their transplant pharmacist to be Alyssa, or I want to only look at ones results that include an immunosuppression level, or I want to only include ones that have a PharmD protocol. And so there's various ways that you can filter this, and you might have different reasons, workflow reasons, to filter it by different results. What the nephrologists typically do is they use this ordered by me filter. And so they're just looking at everything that's ordered by them. So, and then, when we implemented Epic, we were coming from kind of a homegrown system where there was a shadow charting of their immunosuppression drug levels in this homegrown system called Max. When we went live with Epic Phoenix in 2021, our transplant coordinators wanted an easy way to view the history of the dosing and the dose changes, and the providers wanted this too. And we struggled with our Epic IT team. They had initially proposed synopsis view, but there was disgruntlement over the fact that the tacrolimus was listed as two different line items because of the different strengths of the dosing, and they couldn't tell the combined dose. And so they pushed hard to make this flow sheet where people would just free text type in the dosage. And I argued against this at the time, but for better or worse, it is here, and I'll show you how this is used and shown up. But this is where the nurses then track the dose changes. So when we started doing the immunosuppression management in 2022, we wanted our own synopsis view to be built. They had built ones at Go Live, but none of the nephrologists were really using them when they reviewed immuno. And we thought, well, this is really, I think, the best screen, because it's a synopsis view, allows you to pull in the immunosuppression prescriptions, their levels, result notes, other prescriptions for other relevant drugs, their chemistries. We're able to put in pathology results in here, their AlloSure, their DSAs, like lots of relevant things. And on this screen, you can also see that the immunosuppression medication on that flow sheet can blow into this synopsis view as well. But this is a way that then I can double check, like, is there a discrepancy between the actual prescription and the dose that has been directed for the patient to take. So you can see here on this example, this is like a little bit zoomed in, where this patient, between post-op day 9 and 13, they were on this the prescription was for 1.5 milligrams every 12 hours. It's a combination of 1 and 0.5 capsules. But then if you look at the flow sheet, just scrolling down, there was actually a documented change on post-op day 13 that they decreased the dose to 1 milligram every 12 hours, but they didn't update the prescription. So, and this was a workflow that had been happening in our transplant nurse coordinators in the regular workflow where the physicians were directing to the transplant coordinators change the dose. It was like a one-liner on a result note that was sent to the transplant coordinator, and then the transplant coordinator would implement this. We want to do better. We want to, make sure the prescription was updated every time, and that's the best practice that we've encouraged all our nurse coordinators to do as well. But there's variable adherence to that. So when we do it, we update the prescription, but then also we update it on that flow sheet. So it's a little bit of double work. Now, one concern with this is catching people that are overdue for labs. So we had a reporting workbench report built for us that was able to incorporate that lab due date field that we created on the transplant tab to then sort patients, with a transplant PharmD protocol. That's how they then appear on this report that identifies them as needing to appear, and then we can sort them by their labs due. So this is essentially a way to collect all those patients we're following. We're following now, at this point, over 200 patients for their immunosuppression when we're doing this role. And weekly, we're reviewing, 20 to 30 tacrolimus results. So future directions for this clinic, we're not necessarily experts in Epic IT, and we set this up based off of our own thoughts of how the process would go. There are some things that we still end up tracking separately on an Excel spreadsheet that we're looking to maybe incorporate and get rid of the Excel spreadsheet and do into Epic. One is the referral date, like when patients were referred to us. It'd love to be a discrete field, so then we could identify that on the reporting workbench report. Right now, since we have it in a free text field, we can't sort by that, but we use a separate Excel spreadsheet, and it's like, why are we doing this? We're typing it in 2 places, so we're probably going to get rid of that Excel spreadsheet, do it here. The other thing is the lab frequency, being able to maybe have that as a discrete field, like a drop-down menu, select one of the, a few common frequencies. We could also have a discrete field for the preferred lab or their source of the results, and anticipated handoff date back to the local nephrologist. These are just other things that we're kind of typing in that it might be helpful to be able to filter or sort or do other types of reporting on in the future, but right now that exists as free text data. And then this would also help us to assess program quality down the line, which we haven't done yet. So yeah, that's it for my section. Thank you for your attention and inviting me to the webinar, and I'm happy to answer questions about our process and how we did this.
Thank you so much, Evan. If anybody has any questions, feel free to please drop it in the chat for me. Thank you to all the speakers. That was great presentations, especially even for us at TGH here. We've expanded our FTE footprint into the AmCare. So I'm excited to be able to incorporate a lot of this information that our speakers have provided to us. I'm going to go ahead and start off with the first question from Margaret. This question is for Mary. She said, could you please elaborate a little more on how clinical reviews and reminders are entered into Epic at your center?
So the clinical review aspect is based off of the Phoenix platform. And do I have capacity to share my screen? So this is very crude. I tried to pull it really quick. So I saw the question in the chat. But this is kind of a screenshot of that transplant checklist. So this is the Phoenix platform. This would be a patient who just had a liver transplant, and then you can add tasks. And we had Phoenix build us a task for clinical reviews that would then be its own independent ones. We also have the prednisone taper tasks as well. And so those are things are manually added by a provider or a pharmacist that can then be assigned to the pool. And I think for us, the key element for our management is that pool utilization. So that way, whoever, and then that list is generated for anything that's assigned to those pools. And so then whoever is assigned to ambulatory for the day will run that list and then have the responsibility for taking care of the tasks that day. Each one of those clinical reviews can then be changed from the due date. So I can move that. So as the prednisone, as I taper the prednisone, I can move that out 2 weeks later so that then they would be able to address it when it's appropriate for the next time frame. And then when they're filtering based upon the due date, it's taken care of. Clinical review doesn't actually show up in the patient chart, so it's not patient facing. So that can be very nice in terms of like being able to share data without it necessarily being on the patient's page. I think the one aspect it is all available to any provider that's within the transplant team. And so, you know, we've had people that will then take what's in the clinical review and then post it to a note. And so we have, you know, learned to be very cautious of what you're posting in those clinical reviews need to be fairly favorable, right? And so like kind of being mindful of kind of how you're expressing things. But then we will also, whenever I'm doing a task that's related to a clinical review, we'll put in an encounter note that's like my smart form so that we capture the data, because the clinical reviews that in and of themselves are not capturing that data for like pulling a workflow. And then reminder lists, our ambulatory pharmacist is adding the patients that she wants to follow to that list and then removing them when they have graduated per se from that targeted follow-up.
Thank you, Mary. I'm going to move on to the next question from Melissa, and this is directed at Evan. Can you elaborate on what information is communicated to the referring nephrologist while patients are following with a pharmacist from 3 months to 3 years, and have they been receptive to the program?
Yeah, that's a great question, and you know, this was you know, one of the primary concerns going into it. What we do is our transplant nephrologist does a warm phone call handoff with the referring nephrologist, and depending on the referring nephrologist and the relationship between the particular transplant nephrologist and the referring nephrologist, some of them also do this like via text or casually, but they will express that, hey, this patient is one of the patients that's going to be in the transplant pharmacist managed immunosuppression program. Our outreach also hasn't been involved in this, and like we told all of the referring practices, like this is what's going on, and if you want to like opt out of this program, you know, to discuss that with the transplant nephrologist. Our transplant nephrologists have been big advocates for us in saying, you know, to the referring nephrologist, this is the best care. This is what we think should happen with your patients. That being said, there has been two nephrology groups. One is Kaiser. Kaiser really likes to manage their own patients, so we don't follow Kaiser patients. And then two is there's just one particular practice that had a good workflow in place already. They wanted to be more involved in the management of their patients, and they decided to kind of opt out of the pharmacist managed immunosuppression. But for the most part, the reception has been good from the local nephrologist. The local nephrologists also get a letter that has it on paper, the exact kind of description of the program. So their office staff is also aware, and we fax that letter to them. So there's both a warm verbal handout physician to physician, and then there's the nurse coordinator sends the letter to the referring office, because the referring office needs to know that, oh, when there's a TACRO result, like, they should leave it alone, right? They shouldn't do it. And early on in implementation, we did have a few instances where the local provider was still doing something with the TACRO when we were supposed to be doing it. And so in those cases, as those came up, which only luckily came up a handful of times, you know, we would discuss that with our transplant nephrologist, who would then reach out physician to physician and say, hey, look, you know, our pharmacist is managing this. Them. Now, we don't personally interact with most of the referring nephrologists. That's something we're looking forward to doing more. We copy all of our notes to them, but we don't like have a phone call or any verbal interaction with them. But hopefully later on, we'll get to go on some of the outreach meetings that our physicians do to the local nephrologist, to at least put a face to the name, so that they know when they're getting our copied notes to them. Because we just fax them, you know, we CC our note. Whenever we adjust the immunosuppression, we CC it to the referring nephrologist. So they at least are in the loop with what's going on. But I think some of them, it would be nice to develop that relationship more. But one of the quality metrics for the program that I had thought about and think that we should survey at some point is a survey of the referring nephrologist to get their opinion on what they think of the program. And we think it's a great service. We think we're saving them some work and helping their workflow, but some of them might view it as maybe a little bit of, they might feel uncomfortable with that lack of control of their patient.
Thank you, Evan. We have a few more minutes, and there is quite a few questions in the chat. So I'm just going to go in order. The next question is from Heather, and she actually had the same question I did. But she said, great talks. Thank you all very much. She's wanting to know if any of you guys are billing for your pharmacy service. And the second part of the question is, are you using any IVENs? And are you all finding that to be beneficial?
I'll go first because it's the easy answer. We don't bill for CMV. For anemia, we can bill for the patients we see in clinic because we're physically giving them injections. So we can do like a procedure visit and bill for that. But we're not able to bill for remote management of patients. And we do not use IVENs.
We're currently not billing either. And then we have attempted, but sometimes IVENs I think can be difficult for cross-encounter IVENs, and so we'll use IVENs when they're like inpatient, but we haven't used a lot of inpatient outpatient IVENs.
Perfect. We have 1 minute left. Are the speakers okay to hang on for one or two more questions? Okay, perfect. It's obviously a very interesting topic, so a lot of interest from the group here. This next question is from Jeff, and this is directed at Mary, and he said, for your transplant pharmacist assessment smart forms, what type of encounter does this go into? And then is a note in the documentation encounter or the clinic visit? And do you have to open a separate encounter to use the smart form?
So yeah, so you will need to use an ambulatory encounter of some kind. That can be documentation, telephone. It can be in association with a clinic visit encounter, even if it's like a provider add-on. So it doesn't necessarily have to, you specifically have to open up an encounter, but they have to have an encounter in the ambulatory space that can be accessed. the documentation into a note from the smart form is a dot phrase that is utilized to pull that data into the note. So you can actually enter the stuff in the smart form and actually not post it into a note, and it would still capture that data in the smart form, but it wouldn't be able to demonstrate your work to like other people as captured, if that makes sense.
And did you build the smart form yourself, or is it something you have
We
to
had
put
our
into
IT. We have a
ticket?
pharmacist that works kind of in their outpatient space that worked with our transplant pharmacist to say, what is important to you? What do we want to capture? And so it was very much of a hands-on kind of back and forth. We initially, before we used the smart form, had a smart phrase or a dot phrase that we utilized that was for transplant follow-up, and that data would get captured in the backside. But it was a little bit more cumbersome and a little required maybe a little bit more intervention, whereas these smart forms were a lot more quick and are able to be captured pretty quickly and consistently. But you do have to open an encounter. So if I'm going to document something, I have to open up them or do an orders only if I'm sending like a new prescription or something.
This next question is from Adam. And he said, have you handled any follow-up labs that result during off hours, weekends, and holidays where you don't have someone actively covering the service? And he's particularly interested in how you handle critical values, such as undetectable or very high trough levels. And I maybe a little bit more directed to Evan, right? Because I think you do a lot of the TAC monitoring and pulling labs.
Yeah, sorry, I was just typing it in the chat. So yeah, I mean, we for what we're responsible for, the immunosuppression labs, we do not review those on weekends or after hours because of our workflow. A lot of that it's not even getting entered into our system after hours or on weekends. You know, if there was something that the performing lab found critical when it was run, you know, they have the contact number of the physicians and the on-call provider. You know, our names are not on the order, right? So if it's like a hyperkalemia, like patients, you know, critically high or low or whatever, then it would get paged to the on-call medical provider. But for the immunosuppression labs, you know, we're not considering any of this like super critical. If they're transitioned to us, we're capturing people in this 3 months to 3 year time frame that, you know, they should be able to accommodate like a 1 to 2 day business day turnaround for reviewing their labs. And so we usually, realistically, for a lot of the outside lab results, we don't get the tacrolimus resulted for, you know, sometimes 2 to 4 days after they actually have the lab drawn. So, you know, if we found that they were critical, we would have them done here. And we do sometimes have patients early after discharge that we think, oh, we really need to keep an eye on their TAC. And then those are done at our own institution. And if there's going to be a weekend one, everybody knows that, oh, it's going to be done that day. And we sign it out to the on-call people. But again, those are not the same patients that we're following. I'm following like stable kidney patients that are like beyond 3 months. If they're if they're really dynamic with their immunosuppression, then they would be followed more closely by the medical team.
And then I'm just going to chime in quick because we do follow, you know, the CMV levels. So we get all of those back. So if we get them back, not during business hours, some of them do result to our phones because we have Haiku. If any of you guys use that on your phones, or like Epic will give you labs. So between May and I, the other pharmacist, we both work every 4th weekend. So one of us is usually working the weekend. We'll address them then. But we also just get secure chats from the coordinators and we'll kind of just respond to them. So we kind of treat it as it's not really like a 9 to 5. We get secure chats any time of the day. And then we just respond to those and oftentimes can like direct the coordinator what to do. Like if they need to start val site, if they can stop the val site, that sort of thing.
And I see some of the questions were answered in the chat. I think everyone can see it. Let's see. I just had one more additional question I wanted to squeeze in for Mary. I saw on some of your templated smart forms, you do have timestamps in, you know, times that pharmacists are spending with the different activities, and also just with some of the intro information you're saying in leveraging Epic to be able to use data from Epic to garner your 3 additional FTEs. What are you guys looking at any metrics from an ambulatory care standpoint? And then what did you use to pull from Epic to get those FTEs?
So when we initially pulled data, it was primarily driven by our inpatient activities of what pharmacists were doing. So whether that was like utilizing cutting thymo, better hepatitis B practices for minimizing HepaGam. And so we're able to just use service volumes, our liver transplant services, both intestinal rehab as well as transplant and surgical services. So it carries a really heavy load. So we kind of leverage some of those resources to initially get our first practice, utilizing a lot of specialty pharmacy resources to fund some of our ambulatory processes. So hepatitis C is a big, we use hepatitis C positive organs, as I'm sure many of you do, and that can be a large garner. So leveraging that for those resources. But I think that's been kind of our major drivers. Was initially we got buy-in from our providers, and then both our kidney transplant team and our liver transplant team recently did performas for program growth. And our coordinators and our physicians asked us if we wanted to include a pharmacist resource in that growth. And obviously we said yes. And so when the proforma was approved by the hospital, a pharmacist was also approved. So we have a brand new liver resource that's coming, and that was approved through a proforma. I think it would have been harder to grab from just data capture. And then so that's one of the biggest thing that when we've gone for resources is really utilizing our physician colleagues and our groups to advocate on our behalf, because I think it sometimes can be very challenging to say, you know, what we did. So we used kind of cost containment on the inpatient side plus provider support. And then
that's kind of similar how we got our additional FTEs as well. But I was just curious because are any of Evan, Jillian, or Mary, are you guys capturing any specific metrics that's being asked by the pharmacy department or anything? I'm just curious because right now the only thing in the AmCare setting that we have is we do have like productivity where we're just kind of tagging like activities and they're just, you know, kind of hand entering some time that's associated with it. But you guys obviously, you guys have a lot of more things that you can quantify probably than us.
Yeah, like so for CMV, we tracked like GAN resistance and showed that we decreased GAN resistant CMV and admissions for treatment of CMV. And then we tracked like how many patients were following. Like originally when we first started the clinic, we had a lot of patients on preemptive treatment, but we were able to like stop doing PEM and get them on letermovir. So we've tracked some of those different things and then presented those to the transplant department as well as the pharmacy department to expand our FTE for the clinic.
Yeah, the position for the immunosuppression monitoring was based off of math done about, you know, the amount of physician time saved and the amount of reimbursement that we could get from billing insurance. So we do bill, we're credentialed, you know, providers and with insurances and can bill for the visits that we perform in person as well as telehealth visits. We haven't got to the point of billing all the phone calls because we do call them to change their tacro, you know, and I feel a little guilty about like billing for a 5-minute phone call. And so we haven't gotten to that point yet. And luckily our management has been understanding, you know, because these are patients that previously would not get a bill for that service. And hypothetically, even though we're able to bill per state law, we've not started to bill, but we track, you know, the number of lab results that we review, of course, we track the number of patients we see in clinic, other impromptu phone calls, drug information requests. That's all been tracked historically in our ambulatory care clinic for our pharmacist metrics. And I mean, yeah, we're having no problem meeting our quote unquote, you know, baseline metrics or like what we're supposed to be achieving for our department's goals for ambulatory pharmacists.
Rick, I'm going to wrap it up just because I appreciate the speakers giving an additional 10 minutes of your time. Thank you so much for all the really, really interesting information. I know for sure I'm going to be incorporating it into our practice here. I think one of our big barriers is just getting things built from an IT perspective. So that takes time for us. But And then is it okay, all the speakers, if anybody has any additional information or questions that they can reach out to you via email individually? Perfect.
Of course.
Yeah. Of course.
All right. Thank you so much, everybody.
Thanks again. Have a good one, everybody.